So limb amputation is going to be our last topic for our musculoskeletal system. So that. Fair? Looks like this guy probably had a trauma. You can see that big nick in his bone right there? Probably scar tissue in the bone from whatever trauma caused that to happen. So for assessment, the patho, this is our most invasive option for any type of orthopedic problem, right? So we're talking about joint replacements that have become infected and we weren't able to give antibiotics to clear the infection. So we have to have removal of that extremity, or very, very severe trauma where the option of healing the bone just wasn't an option because it was too damaged. Other reasons that we may have to amputate for patients is something called osteomyelitis. This is an infection of the actual bone tissue. So if we get a colonization of bacteria inside a person's natural bone, it's very, very difficult to treat those infections because bones aren't very well vascularized. So giving IV antibiotics, it's difficult to get the antibiotics to the actual source of the infection. So patients that get an infection inside their bone, we may have to end up amputating that entire bone if we're not able to clear up that infection. And then failed joint replacement, trauma. Yeah. Etiology, how patients get amputations, fairly straightforward, right? Surgical procedure, and we chop it off. So, I'm on the wrong side of my presentation. Sorry about that, I'm wandering. For the assessment, the first thing we want to look at is our surgical wound, right? So this is kind of like our post-op assessment. We want to make sure that the dressing is intact and that there's no signs of strike through. We call the remaining limb from the amputation the stump, and we want to make sure that the stump doesn't bleed. It's very prone to bleeding because there's a very large surgical incision and we've altered their natural anatomy by removing it. So there's a very, very high risk of bleeding associated with patients who have an amputation. And then also for signs and symptoms of infection and wound dehiscence, because we're kind of taking two flaps of skin and sewing them together to close off the body at that stump. There actually is a very high risk of dehiscence, of kind of rupturing of that surgical incision with amputations. So we do need to be very, very careful of that. Then we also need to describe the level of amputation. Whenever there's an amputation being considered in a patient, the surgeon is always trying to leave the most amount of natural extremity present, because the more natural extremity they have, the easier it is to link a prosthetic up to that extremity. So we always want to do kind of work our way up the body. That's why there's so many incremental levels of amputation. The most common ones that we tend to see are below the knee amputations or above the knee amputations, depending on the length. But surgeons are always going to go for as long of an amputation as possible, meaning there's going to be as much natural length to the patient's extremity as there can be. It's going to help with return of function and mobility post-operatively and after healing. Another big one is CMS checks. It sounds obvious because it's a surgery, we're removing part of the body, but it gets weird when we start assessing because your documentation is going to ask you, it's going to prompt you for like, what are their pedal pulses? Well, they don't have a pedal. So we have to think a little bit more critically and assess the most distal, palpable CMS check that we can. So if patients have a BKA or a below the knee amputation, we're going to check their popliteal pulse as their most distal pulse on that extremity. If they've got an AKA, their popliteal is gone, we're going to need to assess their femoral pulse. Same thing with the arm. If they've got a wrist, we may or may not still have a radial pulse, but we will still have a brachial. So we just need to keep working up the body to make sure that we're palpating the most distal possible pulse given the level of amputation that that patient has. So for nursing diagnoses, the things we want to look out for, because amputation is kind of a big deal for patients. They're going to permanently lose a part of their body. This also hits in a couple different phases. One is the physical aspect of the surgery. The other is the psychosocial component. So for the physical, first and foremost, we want to address the pain. And not just their physical pain, but also their psychosocial pain. So things like like phantom pain, which may or may not be associated with actual physiologic injury. Impaired physical mobility, because they're going to have to learn to do something in a way they've never had to do it before, because they now have a part of their body missing. And a self-care deficit for a few different reasons. One is if they have alterations in mobility, it's going to change the way that they take care of themselves. So there's going to need to be some support and teaching around that. The other is that patients may view themselves as having a disturbed body image. So they may not want to participate in taking care of their amputated extremity. So we do need to assess for that. They may have some anger or denial or fear around that new kind of anatomy that they present with. So self-neglect could absolutely be a thing. They're not willing to clean the stump, clean their extremity, or to do physical therapy in order to strengthen that extremity. Also, fear, anxiety, hopelessness, a lot of the negative emotions associated with loss of a body part. So these are all things that we want to assess in our patients, and we definitely need to assess both the physical and the psychosocial components of any type of amputation for a patient. So for our plan, it really depends on where we're at in that patient's kind of healing cycle. So in the immediate post-operative phase, there's a few things we want to do. First, we need to elevate the limb for the first 24 hours to help with that inflammation return. They're losing some of their lymphatic drainage system, so any normal ability that they have to remove inflammation tissue is impaired. So we do need to elevate it and prevent contractures above the level of the joint. One of the key things we do there to prevent those contractures for patients who have had a above the knee amputation, so they just have a stump of their thigh, is we'll actually lay them on their belly in a prone position and have them kind of arch up, because that'll help stretch out a lot of the muscles and tendons on the front of their body so they don't get a contracture where that stump kind of comes up into a sitting position and they can't control it after that because the contracture has limited their range of motion. Other things we want to pay close attention to, compression dressings, so how we wrap that stump. We want to wrap it in a way that's going to promote drainage back into the body, not pool it down at the distal end of that stump. And then always, always, always look for bleeding, right? Because we have a massive amount of incision and tissue damage. Very, very high risk for bleeding. And because all the natural vasculature that was feeding that extremity is now severed. So there's a very, very high risk of bleeding in that immediate post-operative kind of environment. Once it's healed, then we want to assess for skin breakdown, especially where their stump is now interfacing with a piece of prosthetic equipment. So how to take care of their skin, manage that kind of stuff is a big, big deal. Our goals are always to first and foremost keep them physically safe, using Maslow's hierarchy of needs. So good circulation to that extremity. That can include things like massaging the extremity, which promotes circulation. It also toughens up the skin just a little bit on that stump because they're going to now have a new weight-bearing surface from where that amputation is and where any kind of prosthetic device is interfacing with a new weight-bearing surface. So massaging it can help with that, promoting comfort, so addressing pain in our patients, and optimum level of mobility. We want to get them back to as independent a state as possible, always. And for patients with amputation, that's a really big deal, is showing them how they can take care of themselves and really promote their own self-care. For implementation stuff, so the acute implementation in that acute phase, so the surgical phase, we want to look out for surgical complications. Same ones as with every other type of surgery. CMS checks, wound checks, those kinds of things. Physical complications we want to look out for, so actually having to do with that specific type of procedure with that amputation, we want to prevent contractures. So here's that kind of posturing that we can do for AKA, above the knee amputation. procedures is we want to have them lay prone like this, lay on their stomach for 20 to 30 minutes several times a day, 3 to 4 times per day, in order to prevent contracture in their hip. Massaging is a big deal to toughen up the skin on that stump surface where they're going to have a prosthetic interface with it, and bandaging. So bandaging, we always start down at the bottom and wrap up the extremity because that's going to help with venous return and prevent the pooling of inflammatory fluid in the distal end of that stump. So then that's kind of our acute phases. We want to manage the surgical stuff and prevent any complications associated with drainage. For our post-acute, meaning kind of rehab for our patients, we want to focus on ADLs. They're going to need some equipment in order to resume as much ADL independence or function as possible. So that's going to be a big part of the assessment. We have physical therapists, occupational therapy, and prosthetic specialists that are all going to be working with our patients to ensure that the equipment that they're using is fitted appropriately and is going to get them the greatest level of independence possible in their recovery. Another big thing is pain management. And this falls on us as nurses. We want to manage their physiologic pain, so from the actual surgery, and also pain associated with interfacing these new prosthetics. As this skin is toughening up, it can get quite painful for patients. So we always want to pre-medicate them before any activity. And also psychologic pain. So this is a cool thing called mirror therapy. So this patient actually has a right lower extremity amputation. We don't know exactly why patients develop phantom pain. We know there's a physical component due to the actual severing of those long nerves to an extremity, but there's also a psychological component. So when patients see that they're missing an extremity, that causes pain. It's kind of like when kids fall down and hurt themselves. They don't start crying until they see themselves bleeding. It's a similar type of response. The body sees that part of it is missing and it tells itself this is a problem, that hurts. So one of the therapies we do is called mirror therapy, where a patient will put a mirror kind of midline on their body. And it's kind of crazy when it works. It doesn't always work for every patient, but for some it does. When they see that they have a full extremity, which is really just the reflection of their remaining extremity, it tricks the brain into thinking there's not an amputation on that side, which can alleviate their pain. This can be a time when a prosthetic is fitted, especially in that immediate post-acute phase, that rehab phase. So then the patient will go from this, tricking the brain into thinking that it's an intact body, to physical rehabilitation. It can help with patients' experience of pain while they're doing their rehab. And then rehabilitation, so physical therapy, occupational therapy. We talked about this already, but I do want to really draw a line between the two so you understand the difference. Physical therapy is most concerned with gross motor movements, like large-scale motor movements. So when we talk about moving an entire extremity, an arm, a leg, going from sitting to standing, using big muscles to do big movements, that's physical therapy. Occupational therapy is all about fine motor movements. So it's things like, how do we manipulate things with our hands? How do we dress ourselves? It's a lot of the ADL kind of things that occupational therapy is really good at training and providing adaptive equipment for patients for those types of injuries. So patients with amputation are going to need a fair bit of both types of therapy as part of their rehabilitation. So we talked about wrapping a few different times, and we always want to wrap from the stump up towards the body to promote venous return and prevent drainage at our patient. Here's what that looks like. So this gets really complicated, but the thing you want to pay attention to is we're always wrapping from the stump up the body, because that's the way we're going to help to promote drainage. The other pro tip I've got for you guys is when you're wrapping somebody's stump after a surgery, if it's an above the joint amputation, meaning like an above the knee or above the elbow amputation, you always want to wrap above the next highest joint. So in this case, this patient has an above the knee amputation. We're going to wrap up to the hip because that's the next highest joint. That next highest joint is going to be the anchor to hold the rest of that dressing in place. So always wrap higher than you think you need to. Same kind of thing here. So we've got an above the elbow amputation. So we're going to wrap above the level of the shoulder in order to anchor that dressing. So that's what that'll look like. For patients who have a below the knee amputation, we're always going to wrap to above the knee in order to anchor that wrap for our patient. So the evaluation component, physical, we want to focus on a few different things. We want to see that their wound is healing without complications, meaning there's no skin breakdown, meaning the wound hasn't dehisced, no signs and symptoms of infection, and no contractures in that immediate postoperative period. And then ADL completion, we want to see them starting to practice independent self-care with their ADLs as quickly as possible. In the hospital setting, this may be really modest. It's things like dressing themselves, brushing their teeth, being able to transfer to and from a toilet, things like that. As patients go through their rehabilitation, we're going to focus on more mobility and getting up to whatever kind of ambition level they may have or is appropriate for their age. Then the psychosocial stuff. So we're going to start this in hospital care, but this is going to continue for years after patients have these procedures. First thing is acceptance, because this is going to really impact the amount of participation they have in their recovery and in their therapy. So we always want to pay attention to how well are they interacting with their stump, the remaining part of their extremity, and are they able to kind of participate, or are they denying that there's a problem and kind of practicing avoidance behaviors. And then pain control. So they're going to have physical pain from the trauma. And there's also going to be psychosocial pain, so mirror therapy, music therapies, a lot of complementary pain interventions are really helpful in both the short term and the long term for patients with amputation. That's it for amputation and our orthopedic stuff.